Hi guys, let's see about carcinoma of rectum. It is usually seen in people more than 55 years of age. The main risk factors are alcohol, inflammatory bowel disease like ulcerative colitis and Crohn's disease, familial adenomatous polyposis, consumption of red meat in increased quantities, and family history of colorectal carcinomas. Pathogenesis is adenoma dysplasia carcinoma sequence, and main gene mutation is APC gene, which is present on chromosome 5, and then KRAS gene, KRAS mutation, and SMAD4, and P53 is a final hit mutation. The main clinical features for carcinoma rectum is the earliest symptom is bleeding per rectum. It is usually painless and it is bright red in color. It can be either associated with mucus as a bloody slime or can be mixed with the stools itself. Tenesmus is the complaint when the patient has a sensation to defecate but he is unable to defecate. In spurious diarrhea, over the night, the mucus accumulates in the rectum, and early in the morning, the patient wakes up with the feeling to pass stool and he'll pass the mucus. So it is spurious diarrhea. It's falsely like diarrhea, but actually it's only mucus. And altered bowel habits, loss of appetite and weight is seen in mostly metastasis to lung. Investigations to confirm the diagnosis, you have to do rectal examination, proctoscopy, sigmoidoscopy, colonoscopy, and carcinoma embryonic antigen, ultrasound abdomen, and transrectal ultrasound is more used for staging of the disease, CECT and MRI. Differential diagnosis for carcinoma of rectum are amoebic granuloma, endometrioma, solitary rectal ulcer syndrome, and strictures due to inflammatory bowel diseases. Spread of the carcinoma rectum, locally it spreads first circumferentially. First it involves the circular muscles surrounding it, and then it goes to the mesorectum, and then it involves the adjacent structures. Lymphatic spread, mostly it spreads upwards along the arterial supply of the superior rectal artery. It goes to the para-aortic nodes. Lower one-third of the rectum, it can spread to lateral nodes. Venous spread to the liver is also commonly seen, and peritoneal spread. And we have classification modified, we have Duke's classification, and we also have modified Asler-Collis classification, which states A involves the mucosa or submucosa. B, we have B1, which invades into the muscle layer. B2, beyond the muscle layer. C1 and C2, along with B1 and B2, we have lymph node staging, and D for distant metastasis. TNM staging, T1, the tumor invades the submucosa. T2,